to you, ma'am.
Okay, Saiti. Thank you.
Yes, we are live now, ma'am. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect. Welcome you all for today's webinar, Tnfog Marathon Cme. So it's my privilege. So let us start the webinar with Tamil Taiwan. Lamp lighting.
Lamp lighting.
It's my privilege to introduce the MOC of today's webinar, Dr. Gayatri ma'am. Ma'am is the consultant at Shamla Nursing Home, Trichy. I welcome you, ma'am. And also Dr. Radhika Gauri ma'am. Ma'am is consultant at ESIC Hospital, Tirunelveli. I welcome you, ma'am, and I hand over the session to you.
Thank you. Thank you, Sagiti. So, welcome. Dear
Ma'am, your voice is breaking.
Next session of Tnfog Marathon. I thank and welcome Dr. Vidya Prabhakar ma'am, who is the president, and the secretary, Dr. Sampath ma'am, to introduce the dignitaries. Thank you, ma'am. Hello.
Good evening, Radhika. See,
Good
this
evening,
is
ma'am.
good evening. This is the Tnfog Marathon Cme, which is conducted every month, second Friday. We have 3 sessions. One session being the Yuva, and the Yuva will be giving the talk, and the best orator will be awarded under the annual conference. And we have the update. Today we have the update by Dr. Srinivasan, who is the pediatrician. And then we have panel. The November is the month of World Diabetes Day, CA Cervix Elimination Day, Preterm Day, and elimination of violence against women. So we have the topic considering celebrating the all days, each topic. Yuva will be talking about Save the Girl Child and CA Cervix Elimination. Srinivasan will be talking about our Preterm Day, and the panel is on GDM. That is the National GDM Day on November 17th. So I welcome you all for this webinar, from which you can have a good take-home messages. I invite our President, Dr. Vidya Prabhakar, to give the welcome address.
Yes.
The introduce the chief guest. Yes, madam.
Thank you very much. Thank you very much, Sampath ma'am. And thank you, Radhika, for being the MOC and being a pillar of all these marathon CMEs. Actually, so this is the
Thank you, ma'am.
brainchild of Dr. Sampath Kumari ma'am. And as she has very rightly pointed out, what are all the various features of the marathon CME? Usually we find that it is usually dedicated to one particular topic, but this month, since so many things were there together, this month we are representing the girl child, I mean, the violence against women, everything. So I think this time she has combined so many different topics together. Otherwise, normally it is one dedicated topic and we talk about that one topic in detail. So today, for a change, we are having a lot of topics. And I would like to welcome our chief guest, Dr. Anju Soni, and guest of honor, Dr. Kunjumuddin. Yeah, can I have the CV? Yeah. So I welcome Dr. Anju Soni, ma'am. She is Vice President Foxy 26 and President IMS 24-25, and she's VP Endometriosis Society of India 2025 to 2027, Governing Council member of ICOG from 23 to 25, member India CCM 22 to 25, Chairperson HIV and AIDS Committee Foxy 22 to 23, Secretary General IMS, President. So she has been holding a lot of posts and a lot of important posts and making a lot of impact on the OG community. And she's, as you can see, that she's been in all these positions. So definitely she's very, very passionate about teaching. She's also been editor of Poise magazine.
Thank you, dear. Thank you. Thank you. Thank you so much.
Well accomplished guest today we have. Welcome, ma'am.
Thank you so much for such a kind and generous introduction. And at the offset, good evening to all of you, my esteemed colleagues, organizers, and dear friends. It's an honor to be here with you today at your TNFOG event, which I just heard that you're having it every month. And my sincere thanks to you, Vidya, President for TNFOG, and also to organizers, Dr. Secretary, Dr. Sampath Kumari, to make this event possible. You have already told that there are so many days which we are celebrating this week. Today is a Children Day. Today is also the Diabetic Day, and in coming days we have this cervical vaccination and preterm day. So you have combined everything together. So but I would like to specially mention for Dr. Sampath Kumari. We all know that she's going for the post of Foxy President election next year, whose dedication and efforts are there to organize this event. And you people are doing a great effort by engaging the younger colleagues, which is truly commendable. And talking about Dr. Sampath, her leadership is shaping the future of our field, and one of the most urgent issues which you have taken, Save the Girl Child, which includes a very, very grave issue of child feticide, and also the practice of selectivity of aborting female feticide is violation of girl child fundamental rights as healthcare professionals. It's our responsibility to advocate every girl's right to live, thrive, and reach her full potential. Dr. Ashika Kme will lead the session, and I'm confident her insight will help strengthen our collective efforts. Coming to cervical cancer elimination, it is another crucial topic with the advancements in HPV vaccination and screening. We have the tool to prevent the cervical cancer. Dr. Mahalakshmi, we will share the latest strategies to eliminate this preventable cancer. We must continue to engage regular screening and vaccination. We also we will also discuss preterm births with Dr. Srinivas S, focusing on reducing risk and improving outcomes. Dr. Meena Mahalingam and all the panelists will address very, very crucial topic, gestational diabetes mellitus. We all know that in our country, we are now leading with lots of women coming to us with GDM during pregnancy. And sharing the key management practices for the healthier pregnancy is very, very crucial. And finally, I must again say that Yuva session moderated by will bring a fresh perspective to the new generation of professionals, and I look forward to this engaging discussion ahead. And I want to thank all of you once again for inviting me for today's session. Thank you very much for inviting me. And
Thank
best
you,
wishes
Dr.
to Dr. Sampath Kumari for all your future endeavors.
Thank you, Anju. With all your supports, I think we should come over. Thank you for accepting.
Thank you.
Thank you very much, Dr. Anju Soni ma'am. So that was really a very generous, a welcome address that you have given for us. And I'm sure actually what I've found is almost all the guests in this program have always been appreciative of the Yuva participation. So, and you are also so, fascinated by that Yuva participation. Actually, Dr. Sampath Kumari makes sure that in every program, the Yuva get their dues. So I think that way we are encouraging the Yuva. Thank you very much once again. And I would now like to welcome Dr. K.U. Kunjamoideen. He and I have worked together for about 10 years. And he's got 25 years of experience in the field of reproductive medicine and gynec endoscopic surgery. He does endoscopic surgery not only in India but also abroad. Senior consultant, ARMC IVF Fertility Center, Kozhikode and Perindalmanna, Kerala. He is the founder, managing director of ARMC IVF Fertility Centers in India, where I used to be earlier. Founder, chairman, ARMC Aegis Hospital, Perindalmanna, Kerala. Visiting consultant, IVF specialist, modern, Al Salama Medical Center, Muscat, Oman. And visiting specialist in Kim's Health, Dubai. Visiting specialist, Aster Hospital, Al Quaziz, Dubai. Visiting specialist, Nova Healthcare, Doha, Qatar. And former National Joint Secretary, Indian Fertility Society. Founder, Secretary, IFS Kerala Chapter. And he's also founder, president of Perindalmanna OG Society and vice president of ISAR Kerala chapter. So, and also very jovial and humorous person, apart from being a fertility specialist. I welcome you, sir, for this program. Is he there? I can't see him.
Kunjamoideen? Dr. Kunjamoideen?
I can't see him
Get
actually.
joined, I guess, ma'am.
I tried reaching him a few times, ma'am. It went on ringing. He didn't pick up. Not sure if he's busy.
Okay, Dr. Gayatri, we can Vidya madam. I am in Pune only with this conference. I saw him in the morning. I think he must be busy
Ma'am,
with you.
if possible, once he joins, we will have his intro and his blessings, ma'am. We'll go ahead with the program.
Yes, if
we'll
the
start the
is there,
program.
we can start.
Yes, Gayatri, take over.
Thank you.
Yes, ma'am. And our marathon judges are here who have really been running the marathon as fast as the TNFOG. We have with us Dr. Shanti, Professor, Department of OG, Savita Medical College and Hospital, Chennai. She's an MBBS and MDOG from MMC, trained in ultrasound, advanced fertility, advanced laparoscopy, and also a provider and instructor course. She's got a lot of publications to her credit, and she's been the examiner for UGs and PGs, and also in the Marathon CME for all of us. And she's been the invited faculty in a lot of national and international conferences. And her field of interest is endoscopy, high-risk pregnancy, and adolescent gynecology. Welcome once again, ma'am. Along with her, we have Dr. Kartika Prabhu, who is a professor in SRM Medical College and Research in Katangulatur. She is an MBBS from MMC and MD from JIPMER, an undergraduate and postgraduate teacher. She's got a lot of awards to her credit. To name a few, Dr. A.V. Umeachi Award, gold medal, Dr. Asha Pakshi Award, a lot of prizes in case presentations and paper presentations in Yuva Foxy 2011, DIPSI 2013, gold medal winner in the Research Day SRM 2000, and AL Mudaliar Traveling Fellowship. She has a lot of publications to her credit, and she's been a faculty in a lot of national and international conferences. Her field of special interest include high-risk pregnancy, gynec endoscopy, and midlife health. Over to the judges.
So first, we'll like to introduce Dr. Ashika, the Joint Treasurer from Tirunelveli Ops and Gynae Society. She is also Joint Secretary for IMA Tirunelveli She is a member of Foxy, IAGE, and she has received first Dr. A.V. Makshikai Memorial Gold Medal for securing higher marks in PG in JIPMA. She has also got lot of awards, Siva Econ Award. Dr. Ashika will be talking about Save the Girl Child. Over to you, Dr. Ashika. Ashika, you're not audible.
No, ma'am. Not audible.
Ashika, you're not audible.
Please unmute her. I think you people muted everyone. So please unmute. Dr. Ashika.
Ma'am, she has already unmuted, ma'am, but there was some problem with the connection, I guess.
Okay. Then
Ashika, is your
Kindly
mic
remove the
connected properly?
earphones and
Yeah,
check.
baby, is your mic connected properly?
you can see her. She's there.
Yes,
Yes, ma'am,
ma'am.
she's there. Ashika, ma'am, disconnect your earphones and check once, ma'am.
Okay, if she's not ready, should we move ahead with the next person?
Better
Yes,
you
ma'am,
can
let's
go
save
with the
time.
next Yuva.
Mahalakshmi, ma'am, are you there?
Ashika,
Not
we are
audible,
still not
ma'am.
able to hear you. Do one thing, use another name and get connected from your phone, no? In that case, you can use the system for PowerPoint, and for volume, you can use your phone.
Mahalakshmi, ma'am, are you ready, ma'am?
Ma'am, start my screen sharing.
Yes, ma'am.
Okay, Ashika,
One
get ready.
second.
We will finish with Dr. Mahalakshmi and come back to you.
Okay, ma'am. First, we will give the introduction of Mahalakshmi, ma'am. Gayatri, ma'am, please take over.
We have with us Dr. Mahalakshmi, who's finished her MSOG in 2020 and now is a consultant at Anirudh Hospital, Uttrangarai. Her special interests include infertility and high-risk obstetrics. Over to you, madam. You are given 12 minutes to finish your presentation and a 3-minute for discussion. You also have points for completing it on time.
Good evening, everyone. Since November 17 is the World Cancer Cervix Elimination Day, I think this topic would enlighten us about the preventive methods. Cancer cervix is the second most common cancer in Indian women. An estimated 1,23,907 new cases are diagnosed each year. The median age of diagnosis is in the reproductive age group around 38 years. So the 5-year survival rate is 48.7%. In August 2020, the World Health Organization has started this emerging global strategy to eliminate cancer cervix. The vision is to create a world free of cancer cervix, and to reach this, each country must achieve maintain less than 4 cases of cervical cancer per 1 lakh Indian women. There are 3 control targets for this global strategy. 90% of the girls must get vaccinated by 15 years of age, and 17% of the women must be screened with HPV test at 35 and 45 years of age, and 90% of the women must be identified with cervical disease, proper treatment for the precancerous lesion or invasive lesion. And today's discussion is about the risk factors, awareness, vaccination program, screening program, and treatment modalities of pre-malignant lesion. The main risk factor for cancer cervix is the human papillomavirus infection, which is contributed by multiple sexual partners, early age of sexual activity, early menarche, low socioeconomic status, long-term use of hormonal contraceptives, high parity, tobacco smoking, and immunocompromised host. Early stages of cancer cervix are asymptomatic, so we need awareness for early detection of the symptoms. The main symptoms include vaginal discharge, irregular vaginal bleeding, pelvic or abdominal pain, postcoital vaginal bleeding, In advanced cases, women may experience foul-smelling vaginal discharge, pelvic or abdominal pain. Let's talk about the vaccination. Ideal age for HPV vaccination is among 9 to 10 years of age group for both boys and girls. Catch-up vaccination is available up to 26 years for females and up to 15 for males. Available vaccines include quadrivalent and monovalent vaccine. The schedule remains for 9 to 14 years, 2-dose schedule, and for 15 to 45 years and immunocompromised people, 3-dose schedule. If it is bivalent, 0, 1, and 6, and if it is quadrivalent, 0, 2, and 6. Pregnant mothers should not receive the vaccine. All lactating mothers must be encouraged to give HPV vaccination when they come for postnatal follow-up. And almost all vaccinated women should undergo regular Pap screening. Next, we will see about cervical cancer screening methods. Different types of screening methods are available, and they include most commonly used via in peripheral settings, Pap smear, LBC, HPV DNA testing, and more peculiar like colposcopy and polar probe or in recent use now. Via visual inspection with acetic acid, we use 3 to 5% of acetic acid applied to cervix and visualized. Abnormal precancerous cells will have astro-white brightening areas. Visual inspection with Lugol's iodine. Normal cervix will be rich in glycogen and will stay in brown color. Precancerous lesions will be yellow or saffron yellow. If viability is negative, you can follow up the woman after 3 to 5 years. If it is positive, immediately treat her with colposcopy and biopsy. Suspicious people must also receive colposcopy. Benefits of viability, since it acts like a point of care screening, we can do early detection, and it's very useful in low research requirement, and immediate results will be available. Pap smear, this is the most common method of screening used by everyone. Exfoliated cervical cells are scraped from cervix by spatula. Entire T-zone must be sampled. Endocervical canal sampling will be obtained by a swab or cytobrush. So this is the image showing how to take a Pap smear. Next is the LBC. In LBC, the sample is collected using an endocervical brush, and it is immersed in a vial containing a liquid preservative. The liquid will remove all the mucus and blood stains from the cells, and the liquid is processed to create a thin uniform layer of cells which is smeared on a glass slide, which is then examined for cytology. So this picture illustrates how to do a LBC. Advantages of LBC: improved sample quality, enhanced accuracy, and we can also do HPV core testing along with this. Disadvantage is quite expensive than Pap smear. Next comes the most important test, HPV DNA testing. By using hybrid capture, we can have high sensitivity towards the oncogenic strains of HPV. Other methods used are PCR and in situ hybridization. So this image shows the guidelines for screening. No need to do screening for age less than 21 years. Regular persons aged between 21 to 29 years of age should undergo cytology every 3 years. From 30 to 65, cytology every 3 years, and HPV testing once every 5 years. If it is done by co-testing, like PAP with HPV or LBC with HPV, testing is recommended every 5 years. Age people more than 65 years, no need for screening. And in women who have undergone hysterectomy with cervix removal, no screening is required if they don't have a history of high-grade precancerous cervix lesion. This slide will give us the management of women with atypical squamous cells of undetermined significance. If it's only atypical squamous cell, you can repeat the cytology in 6 to 12 months interval. If both the tests are negative, we can do routine screening as per the schedule. If both the test remains positive, you can direct the woman to colposcopy. And if sometimes the HPV test becomes positive, again you have to refer the mother to colposcopy for further evaluation of SIN lesions. Next, we will see about colposcopy. So in colposcopy, we can identify the normal landmarks of the cervix, and using this, we can see the abnormal areas in relation to normal landmarks. It facilitates direct biopsy and it's definitive method to rule out invasive cancer. The principle behind colposcopy is pre-malignant and malignant cervical conditions will produce colposcopically identifiable epithelial changes that generally occurs within the transformation zone. So we'll say about squamous metaplasia, physiological replacement of columnar epithelium with squamous epithelium. The region where this occurs is called transformation zone. This is important because almost all cervical cancer occurs in this zone. So this is the normal colposcopic finding showing the new squamocolumnar junction. The surrounding light pinkish area is the metastatic squamous epithelium, which is surrounded by the original pink original squamous epithelium. So what are the indications for colposcopy? Any suspicious visible or palpable lesions in the cervix, consider colposcopy. PAP consistent with dysplasia, refer for colposcopy. PAP with evidence of HPV infection, refer for colposcopy. Follow-up of previously treated patients, they need colposcopy. So how the procedure is carried out? Insert the speculum, apply normal saline, apply 3 to 5% acetic acid, and then apply Lugol's iodine. Perform cervix biopsy from the abnormal areas, and also it's recommended to perform the endocervical curettage, inspect all of the vagina, and also do the bimanual and rectal examination. So the technique evaluates astrocyte changes, punctation, mosaicism, and the abnormal blood vessels. So this is the image showing after application of 5% acetic acid, you can see the squamocolumnar junction. So this is suggestive of a low-grade squamous lesion. This image shows astrocyte lesion in the upper lip of the cervix. So this is the image showing a circumferential astrocyte lesion with irregular margin and fine mosaicism. So this is a classification of colposcopy reporting. Based on the findings, either you can give slightly suspicious, moderately suspicious, or strongly suspicious. Next, we'll see about the polar probe. This is a recent advancement in cancer cervix screening, as it is AA-based. This is an electronic non-invasive device developed for cancer cervix screening. This is like a pen-like device, and this will analyze the cervix tissue and measure its optical and electrical properties, which is then computerized and gives an algorithm-based result. It's like a definitive real-time result. Either the result will be normal or abnormal. Abnormal results will be same for further colposcopy. So the advantages of polar probe include this is like very non-invasive, so it's better tolerated among the women than pap smear. Next, we will see the treatment modalities for cryosurgery. Treatment modalities for thin lesions. Either you can have ablative procedures like laser ablation or cold life conization, cryosurgery, loop electrosurgical excision procedure, and finally hysterectomy. Thank you, everyone.
Dr. Mahalakshmi, so what do you think is the most important thing which can eliminate CS cervix?
Vaccination followed by screening in the reproductive age group.
So what is primary prevention, secondary prevention,
Primary prevention is first a school education, ma'am. Education about the high risk factors and vaccination and awareness.
Okay, so secondary prevention is?
Secondary prevention is screening techniques and treatment of precancerous lesion.
So what is the current recommendation for screening technique for CS cervix?
Ma'am, screening must be we should increase screening after 29 to 30 years, ma'am.
Which method we have to incorporate? Which method is recommended?
Cytology.
Only cytology?
Cytology with HPV DNA.
So
About
HPV
30
DNA,
years? Yes, ma'am.
So HPV DNA testing is an important one. So
Yes,
how often you will do when you do cytology with the HPV DNA testing?
5 years once, ma'am.
Okay, only cytology?
3 years once, ma'am.
Actually, you should have elaborated more on HPV vaccination. So because that is the main cornerstone for elimination of CS cervix.
Yes, ma'am. Yes, ma'am. Like covered from screening method to vaccination, everything
So how many doses of HPV vaccination is recommended?
Ma'am?
How many doses of HPV vaccination is recommended?
From 9 to 14 is 2 doses, ma'am. 0 and 6. More than 15 is 3 doses. 0, 1 and 6 if it is bivalent, and 0, 2 and 6 if it is quadrivalent.
Is there a role of single vaccination, single dose vaccination?
Single dose vaccination, I don't think so, ma'am.
Is there anything new vaccine available? It's actually a fourth vaccine. Any other guard, with respect to Gardasil, any other vaccine?
Monovalent vaccine is available.
Okay. Apart from that, we have single dose, and also we have another one, newer one. Fifth vaccine is also available, which is also for 2 doses. That one we have like, it's called a Sicolin, that is single dose. WHO is trying to think, because making this 2 dose, 3 dose available is quite difficult. So they are trying, it is actually in use off label for vaccination in certain places.
Okay.
And what is the efficacy of the vaccine? And how long is the immunity?
This is vaccine.
Around 99%, and they say it is roughly around 10 years, because research studies are still going on, right? Yes. And is there any difference between the vaccination among females and the males?
Yes, ma'am. For males, it also prevents many other HPV related cancers also.
Any age?
And I'm sorry?
Is there any difference in the age of a vaccination of females and males? Females, how long, till what age they can be vaccinated?
I think till 40 years also they could get vaccinated.
Till 45.
Ideal age 45. Yeah. Ideal age is
efficacy varies. Okay, but from 9 to 45 it can be given, but the target is of the global elimination strategy is it should be given before 15 years. Target population is 15 years,
yes, ma'am.
But then it can be given up to 45 years.
Yes, ma'am.
I think it was otherwise it was a good presentation.
Yes,
so for want of time, we'll move on to the next speaker. Is
Thank
Dr.
you.
Ashika ready?
Yes, ma'am. Am I audible now, ma'am?
Yes, Ashika.
Good evening. Good evening, madam. Good evening, everyone. We'll start with the presentation. So, I'm going to talk today on Save the Girl Child. Is my presentation visible now?
No. You have to share.
At first, open the PPT, ma'am. Yes, ma'am. Now we can see the slides and make it as full screen, ma'am.
Okay. Is it full screen now?
Yes, ma'am.
Okay, thank you. Good evening, everyone. Thank you, Tnfog, for the opportunity. Thank you, judges, for presenting. I'm presenting the UA session for the second time. So today I'm going to talk on Save the Girl Child. So I want to start this presentation with a quote. Being a girl should not determine what you can do, where you can go, or who you can become. So why suddenly saving the girl child? It's very important because they carry generations of potential and impact. They are the carriers of a future, and the challenges which they face undermines their ability to reach their full potential and drive the development for the nation as well as globally. It is very important to sustain the investment to ensure that they have a full chance to reach their full potential. So the girl child. The adolescent girls have the right to a safe, educated, and a healthy life, not only during these formative years where they mature into women, they need a safe environment. And if they are effectively supported during the adolescent years, both as empowered girls of today and tomorrow's workers, mothers, and entrepreneurs, and household heads and political leaders. So this is a voice of a girl child. In a world where girls carry our future, it is non-negotiable that we are given equal and fair opportunities and access in all areas. What are the challenges that they face from the womb to becoming a woman? In the fetus, they are burdened with female feticide, and in the infant, female infanticide, and the obstacle race continues further into the womanhood. As a toddler, they have reduced access to nutritional food, gender-based discrimination, and as a girl child, access to education becomes a problem, and the forced child marriages and the nutritional food access becomes again a problem. And in the adolescent, where the mental health takes a toll on them because of the child marriage issues, the menstrual hygiene, and access to education. And when they bloom into an adult woman, the financial independence which they crave and the access to healthcare in pregnancy and childbirth becomes a challenge to them. So at every stage in life, they are burdened with an obstacle. So coming to the challenges they face in the first few years from the fetus to the toddler, I would like to present this video. Is the
Audio.
okay? Basically,
Audio
this
is not.
audio.
Yeah.
So basically, this is a famous video clip from the movie called Karatama. I hope everybody knows it, where they talk about the father of the girl child tells that he has already murdered, he has already killed the previous female child with the milk of the cactus, that is the kalipal, which we call here. So then there is no guilt on his part. And it is because it is the burden of the girl child which worries him more than the act of committing a murder. So, and ironically, when I started this presentation, our PCPNDT Act, which actually was implemented in 1994, had shared the same this thing with release date with this movie, which created ripples in the community. And do we think after all these years the horror has that is a past event? No, it still continues, and this is a recent paperclip in 2025 where we could see an abandoned newborn female infant which was rescued by the rescue team. So this is the state of affairs now. And what globally has been done so far to save the girl child? The UN, after in 2011, has decided to observe International Girl Child Day on October 11th to make sure that empowerment and investment in girls, it is very critical for the economic growth and achievement of all the Millennium Development Goals which they have charted in the Constitution. And it is very important that they are they are the key in breaking the cycle of discrimination and violence. So this is the reason why the UN General Assembly has started observing the International Girl Child Day. So, and this year's theme is The Girl I Am, The Change I Lead, girls on the front lines of crisis. They are not only burdened with crisis, they can definitely come up with solutions as well. So it calls for the recognition of girls' leadership in the face of multiple crises. And what we do in India, it's the National Girl Child Day. So it is observed in January 25th of every year. It was initially coined by the Ministry of Women and Child Development, and it acknowledges the unique challenges which is faced by the girls, including child marriage and gender-based violence. And what has changed in the almost over 30 years when it comes to the girl child? We have seen a drastic improvement in the average lifespan of a 15-year-old girl, and the proportion of the girls who are dropping out of the school has reduced, and the unemployment ratio has decreased, and the child marriage and HPV vaccine coverage has shown a promising trend. And the annual number of HIV infections has reduced, and the adolescent birth rate has reduced from 73 to 38%, and not to 0.8. So our goal should be towards 0. And this is one of the Global Girl Leaders Advisory Group voice. Government should invest more in girls' empowerment programs and support initiatives that enhance their capacity, rights, the leadership, the entrepreneurship, and safety. Your support is crucial in creating a better future for all girls. It is an UN assembly where she voiced out this concern. So what are all the named challenges which the girl child has? Gender discrimination, lack of access to education, abuse, child marriages, and lack of basic facilities. So we are talking about problems so far, and the UNICEF has got a 5 game-changing solution for the adolescent girls. Health services, providing proper health services, providing good nutrition, quality education, safety from violence, and economic support is going to empower them in their future. So the challenges they face, we have seen, and These are the solutions we have from the government. So at every stage of a women's life, that is starting from the fetus till the girl grows into a woman, we do have good acts and good number of acts, I call that, to protect the girl child, to save them from the womb to into the adulthood. So from the fetus, we do have PCPNDT Act, the Muthulakshmi Reddy scheme, which benefits the pregnant mother, and it goes into the infant. And when she becomes a toddler, it is Poshan Abhiyan, and when it is girl child, we have got a number of good programs by the central as well as the state government, which includes Beti Bachao and Beti Padhao, that is save the girl child and educate the girl child, and it has been integrated into all programs. And we do have POCSO Act for abuse against the girl child and juvenile justice acts. And when they come into adolescent, they do have higher secondary scholarship schemes and programs. And when they grow into an adult woman, they do have skill development programs and Pudumai Pen, and the list keeps on going. I have not included because the slides looked almost crowded. So this is what I was actually awestruck by the way it has been implemented by our government. So when you go to Social Welfare and Women Empowerment Department, when you click on the specialization of child welfare, we have these many schemes. And when we go into that, there is detailed explanation about how it can be done. And I know all of you will be wondering that why should we need to know all this? Because to advocate for girls' rights, we need to know what are all the benefits she has already been receiving from the government to ensure proper and optimal utilization of the resources. And when it comes to women welfare, we have a list. And when it comes to special program section, which also concentrates on the women, on the girl child, because and then there is a state resource center for women, which has got a set of good programs, women helpline schemes, including one-stop crisis center. And there is a state award for girl child empowerment. So this award goes to a girl every year who is being nominated for this award to promote the potential of the girl child. And all the district collectors, 3 district collectors, will be receiving awards, gold, silver, and bronze from the government for performing well in working towards the sex ratio of the girl child. And we all know about this Muthulakshmi maternity scheme, which is almost 18,000, and we have the list here how it has been split and given, and it is integrated with the central government scheme to ensure proper implementation of the schemes. And we do have JSSK, where the pregnant women and the sick infants are included and provided free and cashless delivery, free treatment, drugs, diagnostics, as well as free transport back and forth from the institution. And we have for the toddlers, RKSK, and school health program for immunization and nutritional counseling, and Chief Minister's Girl Child Protection Scheme. It's very important to understand the benefits, because all of this is going to have an impact on the society, because the one burden of the girl child is first is education, second is marriage. So everything has been taken good care by the government. So all they have to do is just get enrolled in the scheme. And then Cradle Baby Scheme, which is commonly known as Total Kodandai Thittam, and Beti Bachao, Beti Padhao. This is all the detailed explanation of the acts. And we do have an important act, which is Sexual Harassment of Women at Workplace Act. So this they do have something called as a She Box, online complaint management system. If they are facing any kind of sexual harassment at workplace, they can directly register the complaint. And these are they have given a list of nodal officers as well as the local committee members here. And we have the list for Tirunelveli here. And the next, what has the government done for HPV vaccination? So it has steps to roll out HPV vaccination for all girls aged 14. The previous speakers has elaborated about the vaccination schedule. And this is the Ministry of India and Child Development, and this is the portal for it. And these are all the important schemes which I've already described. A scheme for promotion of menstrual hygiene is one important initiative by the government for provision of safe and hygienic menstrual for provision of sanitary pads to the school girls. And this gives a list of strategies adopted by the government of India as well as Tamil Nadu to make sure that at each and every point she receives a proper care and she is not a burden anymore. And it is our duty to support the girl child. And do we have a role here? And this is one disturbing post which I came across while I was doing this presentation. This is a Facebook post by one of the hospitals in one of the metropolitan cities, where they have just told about the pregnant woman, whether she is with a girl or a boy, and how she actually has some kind of characteristics which tells them it is a girl or a boy. So this is a start of gender discrimination. So as medical professionals, we should be very vigilant in our post as well, because this is one of the leading hospital posts which I came across, and our role here. So what are we going to do in this big issue of saving the girl child? So preventing sex selection, implementation of proper PCP-NDT compliance, ethical ultrasound, and family counseling becomes an integral part. And then when it comes to pregnancy care, make the giving a respective maternal care, maternity care, and maternal nutrition and high-risk screenings, make sure that the women ensures a safe delivery. And for safe delivery, skilled birth attendance, newborn care, and breastfeeding support, childhood support in the form of counseling for equal care and vaccination reinforcement. Adolescent health, the adolescent health clinics are available, and menstrual hygiene education and HPV vaccination awareness from our side. And prevention of child marriage, community awareness through school engagement, and women's rights, contraception counseling, and safe abortion access. And violence response, identifying abuse
Sorry
and
to interrupt,
providing.
doctor. You have 1 more minute.
Okay. Providing crisis support and referral, and leadership and advocacy for leading on the public campaigns and public education. So this is our FOXY initiative, Milan Smriti Award to Save the Girl Child, where we list all our activities for the award. And can we do more? Yes, we can display government schemes at the antenatal care and hospitals, because it is a long list, and useful links in the hospitals, and display the benefits that the girl child gets from the government. It helps in non-prioritization of the babies in the family. Every journey starts with a single step. And this is one video where this is a village called Pilantri in Rajasthan, where it's in Hindi, where the village head takes the girl child in his hand. The doctor initially thinks that he's going to do something with the girl child. And what he does at the end, they actually plant trees whenever girl child is born in that village. So he has planted almost more than 300 trees, and they usually deposit an amount of 21,000, which is headed by the community for the girls' education, and they will get a sign from the couples, that the parents, that she will not get married before 18. I think this is an example of how the girl child should be saved and how she should be celebrated. So this is how we win. We save the girl child. And I would like to conclude my presentation with our Mangayara Pirapadarkin Alla Madhavam Seididal Vendumama. Being born a woman is a blessing earned through great virtue and divine grace. Illathen illa vaalvathu polladu, illathen illavan thalvu. A house without a good woman falters. A man without such a woman falls. So this is why we should save the girl child. Thank you.
Good presentation, Ashika. We have covered everything.
Yes,
From
almost
preconception
everything.
to womanhood, all methods available. So there is no question.
Yeah.
Thank you, ma'am.
Yeah. Otherwise, see, for my personal view, I mean, apart from your presentation, is the basic concept why we don't want, I mean, why the society rejects a girl child is the safety of the girl, right?
Yes,
that is
ma'am.
one of the aspects which has to be covered, I feel so, right?
Yes, ma'am.
So how, I mean, in the society, so how to change the mindset of the people in the society, that is also have to be given equal importance, apart from supporting a girl child once it is born, right?
Yes. True, ma'am. That is true. That actually, it's a very good initiative. And initially, when this topic was given to me, I was thinking that what should I speak? Then I was overloaded with all the information. Actually, there are lots which is going on in the society, and still there are so many people and so many NGOs who have actively involved in saving the girl child. I think we all, as representatives, we should take an initiative on displaying what the benefits of having the girl child, because once the public sees this many benefits, all the education thing is done, and I think dowry is almost under control, so everything will be a smooth execution afterwards. Thank you so much.
Thank you. Thank you.
Thank you.
That was wonderful presentation from both our yuvas, both doing complete justice to the topics they were given. We all know for the next session, it is an update on preterm. And for that, we have our president and treasurer as the chairperson. I think Dr. Vidya Prabhakar is a little busy. Can you put up the slide for Dr. Saravana Kumar, please? Yeah, he's our beloved treasurer of TNFOG. He did his MBBS from VIMS Bellary, MD from MMC, President OG Society Salem. He's been the organizing secretary of Foxy South Zone Conference with UR 2022. He is the recipient of Foxy Dira Award, professor and HOD in Annapurna Medical College, and he's also a consultant in Malar Maternity Hospital. His field of interest includes high-risk obstetrics and gynec endoscopy. Over to the chairperson to introduce the speaker.
Thank you, madam. Thank you for that wonderful introduction. It's my privilege to introduce Dr. Srinivasan S., who is an expert advisor for child health and NHM Tamil Nadu government. He is a former state nodal officer child health, member of MNCU expert group with the government of India. He is established with 83 SNSU in the state since 2010. That's a very big feat, sir. Established 26 pediatric emergency units in the district. Started Neo 108 first in the country in 2012. Introduced PCV 13 for very low birth weight babies in 2017. Tamil Nadu Best Government Award in 2017. Tamil Nadu Medical Council Best Doctor Award in 2021. Former State Nodal Officer for Dengue and Corona. And I think he is the best person to talk to us about preterm babies and deliveries. Over to you, sir. Thank you for accepting our invite.
Thank you, sir. Sorry, actually, I am traveling in Salem now. Now I stopped my car for 15 minutes and I'll be talking from my car only. I think some of you can present my slides, even though I know my slides very well. But very thank you for all my obstetric friends for giving me an excellent opportunity to talk about the newborn, especially this month being the month for the premature babies, month for the Children's Day, month for the National Newborn Week celebrations. I think that is a fitting day to talk about newborn babies. So what I'm going to talk to you now today, how quality analysis we can do to prevent the prematurity birth and to reduce the death of the premature baby. So that is my, in fact, it's my mission to do this in all my SNCUs, which I am doing. At present, I am inspecting an SNCU at Salem and coming back to Athur for another inspection now. Now you can see from the second slide, what is the burden of the prematurity in our country? See, we see 40, this is the world, global incidence. I will show what is happening in Tamil Nadu also. Around 48% of the babies or preterm babies are dying. That is the most important cause for neonatal mortality. Of course, around 17% to 21% sepsis and birth asphyxia is there. Now, this topic, I am going to talk only about the prematurity. Shall we go to the next slide, madam? Next slide, please. Yeah, this is the Tamil Nadu. What 1 year from last April to this March. If you see there, the death due to prematurity is 41%, which is better than the country because country has shown 49% deaths in prematurity and Tamil Nadu is showing 41%. And you can see the sepsis death and birth asphyxia death also has come down from 22% to almost 11 and 12%. That means we are doing some wonderful job in Tamil Nadu in bringing down the prematurity deaths. But of course, we can do wonders if we start preventing the deaths of extreme premature babies also. That is my core subject now to talk about also. Next. See here, in the last from 2000 to 2020, how the birth asphyxia and sepsis coming down from 2000 to drastically. There's almost 60 to 90% reduction in birth asphyxia and sepsis from 2000 to 2015 and 2020. But at the same time, you can see the top curve. That is the HMD, hyaline membrane disease, which occurs because of the premature babies. It's going really high and high and high. So this is the cause for concern for us. And of course, having a lot of cases of being infertility, and most of the people are approaching the artificial reproduction techniques. You get more triplets and twins and preterm babies. So a big job is in our hand to do all those things. So what we can do for this? Go to the next slide, please. So this is the data last 1 year, especially I'm talking about the Tamil Nadu. You can see almost 1,700 babies are getting admitted in the state in the last 1 year. They are below 1 kg, say 500 grams, 600 grams, and 700 grams. Out of which 67% of the babies are dying, 33% of the babies are surviving. That means even the 33% of surviving babies, are we giving an intact survival in the form of good neurodevelopmental outcare? Whether the nurturing care was given is also a big question. If you see the below 1.5 kg premature babies, around 5,000 babies are getting admitted in 1 year. And you can see only 22% is death is there. That means below 1 kg, we have almost 65% death. And 1 to 1.5 kg, we have a 22% death. Even though there's a silver line between 900 gram and 1,100 gram, but the baby succumbing to hypothermia, hypoglycemia, infections, hyaline membrane disease is more less than 1 kg compared to the above 1 kg. Go to the next slide, madam. You can see in the next slide. Next slide, please. See, you can see I have given the morbidity and mortality data also. More than 1,800 gram, the death is only 1.7%. But less than 1,800 gram, it's almost 19.6% in the state. Birth asphyxia death is 17, sepsis is 17. You can see RDS, HMD, or prematurity is going almost 20.9%. So what we should do for this? Next slide, please. So what I am going to tell you now, we have to prevent this premature babies' deaths. If you take how many babies are getting with the prematurity with the hyaline membrane disease,
Is there a technical glitch?
can you hear me? Yes?
Yes, sir.
Hello?
Now we can hear.
I think just the signal has gone out. See, I am enumerating around 10 causes which we should go about as a qualitative analysis to prevent the prematurity birth and to prevent the prematurity death. So let me see the causes first. Extremes of age is one cause. Maternal malnutrition. I always say to my postgraduates, always aim for triple 10. What is this triple 10? Achieve more than 10 kg weight during the antenatal period. Achieve more than 10 hemoglobin during the antenatal period. Try to achieve delivery will be conducted up in the 10th month, not before that. So my aim is to have a triple 10 for all the Indian women. So this maternal malnutrition and maternal anemia is placing a spoil sport there. Then of course there is one thing called asymptomatic bacteriuria. We all diagnose infection when the people starts complaining about lower abdominal pain or foul smelling discharge, dysuria, high grade fever. Then we get treated with an antibiotic. Of course, there are plenty of mothers where the symptoms may not be there, but still they have an infection in the form of asymptomatic bacteriuria, or they may having a what is called bacterial vaginosis. Even though we have a lot of facilities, but still we don't do rectovaginal swab or something to identify whether infection is there in these mothers, especially for all the mothers in the antepartum period. That is one gray area. And of course, there are some comorbid conditions associated with the mother in the form of heart disease, rheumatic heart disease, anemia, chronic renal disease, respiratory disease, etc. In the AN steroid, the previous slide I was showing, out of 9,000 HMD babies, only 20% of the babies received full dose AN steroid, and 37% of the babies had only single dose of AN steroid. Even though many studies have proven that AN steroid is the breadwinner, it is going to stop the HMD, it is going to prevent many babies from death, but still we are not able to implement in the government side not more than 30% of the AN steroid before going for delivery. Then the preterm care. I will talk about the preterm care as a triple concept. When I say triple concept, three important way of doing this. Number one is thermoregulations. When I say thermoregulations, I am going to maintain a euthermia in these babies, which are dying because of most of the babies are dying because of hypothermia. So when I say thermoregulations, I feel whether I'm going to use radiant warmer, whether I'm going to use transport incubator while transferring the baby from labor ward to nursery, or whether I'm going to do the time-tested Gangaru mother care, which is getting escalated now throughout India as IKMC, that is immediate KMC, that is zero separation of the baby from the mother. That means, by definition, within 1 hour, the baby should be put into the into the chest of the mother, in between the breasts, within 1 hour. Even if the mother is not there, the grandmother or the relative should be given counseling before going for preterm delivery, and this should be done. So the second one is the AEEN, aggressive early enteral nutrition. When I say AEEN, whether colostrum is being utilized in all these preterm babies. You all know that by God's grace, this 28 weeks mother's colostrum is better and superior than the 38 weeks mother's colostrum. That means no center should witness the colostrum of the mother. That means whether the baby is sick or normal or ventilated or intubated, baby should be given colostrum either in the form of oral direct breastfeeding or in the form of tube feeding, or at least we should smear this colostrum in the lips of the baby, so that this colostrum has proven again and again and again that ventilated assisted pneumonia is being prevented, BPD will not occur, ROP will not occur, osteopenia prematurity will not occur, NNEC will not be there. So much of advantages with this colostrum, whether this aggressive early enteral nutrition is being implemented throughout. Then, of course, surfactant and post-surfactant management, and finally, the follow-up care. Next slide, please. So in this, out of 10 problems, I'm going to select one problem, that is the thermoregulation, which I'm going to do a quality analysis, which one is the better. I always prefer a emotionful mother to do this rather than the emotionless equipment of radiant warmer. That means I have identified the 10 problem. Out of the 10 problem, I have identified one problem as the hypothermia. Thermoregulation has to be done. I have identified the procedure as the IKMC and KMC. And I am going to do this as a qualitative matter. Next slide, please. So what I am going to do? So this is the fishbone analysis. Remember 6P. Remember 6P. Number 1P is people. Which people I'm going to do? It is a preterm babies. Number 2P is person. Who is going to do? It is going to be done by the neonatologist or a trained expert staff nurses or the pediatricians. Then place where it is going to be done. It should be done in the NICU. Then fourth, procedure. What is the procedure we're going to do? I'm going to implement IKMC as soon as the baby is born. If the mother is all right, I will do it in the mother. If the mother is not all right, I will do it in the grandfather or some other relative. The fifth P is policy. Is that government is having any clear-cut policy in this? Yes, government of India is going to come out with a guideline and a very clear policy that all the babies should be started with IKMC as soon as they are born. And the sixth P is the performance. That means if we do this all 5 Ps in a perfect manner, the performance is going to be good. This is what the fishbone analyze. Again, I repeat the 6P. 1P is the person. Other 1P is the people. The next P is the person. Third is the place. Fourth is the procedure. Fifth is the policy. And sixth is the performance, which is going to give you very good outcome. Next slide. Next slide, please. Next slide, please. So by doing this, you will be getting two important indicators. One is called the process indicator. Other one is called the outcome indicator. When I say the process indicator, my process is doing an IKMC and KMC. What I have to do for processing, getting good process indicator, I have to train all the staff nurses. I have to train my obstetricians. I have to train my pediatricians and neonatologists. They should be 100% perfect in implementing the IKMC and KMC. That means when I give training, how many people have attended? When so many of people are attended, how many of people are implementing? So if somebody is not doing, then the process indicator will come down. So the process indicator qualifies that everybody is getting trained, everybody is being implemented, the whole state is implementing the process, then you get a very good process indicator. Then of course the outcome indicator, the process indicator is doing to the perfect, then the outcome indicator is going to be very good. Next slide, please. So next slide, please. So this has been emphasized by WHO in 2022, that India, like India, Tanzania, Nigeria, Malta, and other 5 other countries, Around 50,000 mothers have been tested with the IKMC with the support of Norway and Sweden. Next slide, please. So what is the result? Next slide, please. So here, why the study has come. See, it has been found that all these preterm babies and micro preemies and extreme preterm babies, mostly 50% of the babies are dying in the first 24 hours, And 3/4 of the babies are dying in the first 1 week. That means I admit the baby in nursery and start giving the KMC. That means it is not occurring in the first 24 hours. So the research question is whether you are going to do KMC in the NICU or whether you're going to do KMC in the labor ward itself while shifting the baby from the labor ward to the NICU. This is the research question. The research question, the evidence shows that when the baby is admitted from labor ward to the NICU, the time taken for the baby to reach the NICU is say 25 to 35 to 40 minutes. During the time, the child goes down to hypothermia in many cases. Many studies have proven that more than 30 to 50% of the cases is going for hypothermia when they are getting admitted in the NICU from the labor ward. So this is the biggest morbidity we see. To avoid this, when you start doing KMC, there was no fluctuation in the temperature at all. Even though you transfer the babies in the transport incubator, some evidence has shown that the baby is going down with hypothermia. But IKMC evidence has shown that the baby doesn't go for hypothermia. So the research questions is being answered like that. If you start doing IKMC, there is a reduction in the incidence. Next slide, please. Next slide, please. You can see there is a reduction in 40% of the infant mortality. There is 65% reduction in the infection, 70% reduction in hypothermia, 88% reduction in child going for hypoglycemia. That means this is a very, and in fact, the 58% reduction, even when the child was put into CPAP or ventilator or oxygen therapy, the duration of the stay, the duration of the recovery also has improved. So this IKMC and the KMC, continuing KMC in the ward and continuing KMC when the baby is getting discharged, going to the home till the baby reaches 2.5 kg is the best standard now we are going to practice. Next slide, please. Next slide. So, but there are some logistic issues will be there. How you can, somebody may be asking, in fact, the last week meeting, one of the obstetricians asked me, is it feasible to do that? Why do you want to avoid transport incubator? Yes, because it is very difficult, but any program will have your teething issues in the beginning. Once you start doing, persistently start doing, then you can succeed. So I have to counsel the labor ward people, I have to counsel nurses and pediatrician and obstetrician. Transporting KMC, I am going to select the mother or mother, then that is also is going to be issue. When the baby requires oxygen, how we are going to give oxygen, whether the KMC can be given when the baby in CPAP, when the baby is in ventilator, and of course, how you monitor. These are all the logistic issues we have. But we can come over everything in a very simple way by applying our mind and start doing very aggressively. I think we can succeed in all these things. Next slide. So here are some of the photos I am showing. This is a district hospital in Tirupattur where they are strongly implementing the IKMC, where when the preterm babies are born, before birth of the preterm baby, half an hour before, the pediatrician and the staff nurses goes to the family, tell the family and counsel the family that your daughter is going to have a preterm delivery. It is going to be less than 1.5 kg as per the ultrasonographic finding. So we are going to admit the baby in NICU. Many studies have shown that rather than taking in the equipment, better take it in the KMC position, either in the mother or in the grandmother has given dividend. So all sorts of counseling will be done. Then the mothers and grandmothers, they are accepting it in fully. And you can see a grandmother taking the newborn baby and they are escorted by the staff nurses to the NICU. Next slide. So this is next slide. This is what we see in Tirupattur Medical College, where after the birth, the mother and the baby are together are getting shifted to the nursery. Next slide. Next slide, please. So this is a slide taken from Pudukkottai Medical College, where the mother is being allowed inside the NICU. The baby is in ventilator, but still practicing the KMC. That means even when the baby needs oxygen support in the form of CPAP or ventilator, baby need not be present in the warmer. The baby can present in the KMC position. And then the evidence and studies has shown that baby in the KMC position with the oxygen support has given a very good dividend and very good excellent results. Next slide. So this means now the next concept come. So once you start doing the KMC, the mother is going to be there with the baby always. So the new government of India has come out with a new concept called MNCU. At present, we have MNCU in Tamil Nadu government in 4 or 5 medical colleges like Dharmaburi, IOG, and Viluppuram, Tirunelveli, and Tiruvannamalai. Very soon, we are going to introduce in another 5 medical colleges where the mother and baby will be together. A Fowler's card for the mother will be given, and baby's warmer will be there. And most of the time, baby can put around in the KMC for 8 hours and more than that. Obstetrician and pediatrician and nurses are going to work together, and this MNCU is going to be the game changer. Next slide. This is one of the MNCU where you can see the mother and baby are together. Next slide. So this KMC, even though I am talking now, this is not very new. It is an old process. 1990 we started, but somehow we did not practice very well. So there was no clear guideline. There was no scientific evidence. Somebody told to do KMC and we did. But today, WHO has come out with a lot of scientific evidences to practice KMC and to practice IKMC. Now we are going to do in full. Next slide. So this is my last slide, what the WHO says. Now, in 2022, WHO has given a very clear guideline and policy. All the babies below 2 kg who is born either in the theater or the labor ward should be given immediate KMC. The immediate KMC provider may be the mother, may be the relative. The immediate KMC means you can take 1 hour, the zero separation is there, then you can give immediate KMC for all this. Then continuing the KMC in the ward, even during the oxygen support in the form of ventilator and CPAP. Then finally, once you discharge the babies, when the babies attains 1.8 kg and above, still till 2.5 kg KMC can be practiced, and mother can continue to do practice in the home, for which our pediatricians, NS, SNCUs, we spend a lot of money and the operation costs to procure KMC, Lycra, give it to the mother, take it to the house, and do it in the house also, which we are doing. After all, it's going to cost around 200 to 250 rupees Lycra. So once we start doing a lot of IKMC and KMC, which is going to be the game changer. Now I told the triple information. One is the thermoregulation. Next one is the early aggressive feeding. Third one is the preventing the infection. See, when I start giving good thermoregulations in the form of KMC and IKMC, the studies have shown that the mother feels happy. The stress is not there. Milk secretions is more. Feeding has improved. When the feeding has improved and the thermoregulation is being maintained, it's very difficult for the infection to set in. You know that breastfeeding is going to prevent infection. The infection rate also is coming down. So this is going to be the game changer in our era to reduce prematurity deaths in our country. I thank you, all of you, for giving an excellent opportunity to emphasize upon the real importance of IKMC and KMC, which is doable, feasible, sustainable, maintainable, and easily done by even the staff nurses. Thank you very much for giving this opportunity. Thank you, sir.
Thank you, sir. That was a wonderful presentation, and you emphasized on a very simple and effective method to prevent. To maintain the thermoregulation, and especially when you told that it will take around 45 minutes to one hour to shift the patient baby to the NICU, and immediate KMC is going to mitigate this problem. Sometimes we feel that it is not just 45 to 1 hour. It takes sometimes 2 hours, 3 hours also. So all the way mother is able to give a immediate KMC, then that is going to have a very good effect on the baby, sir. And I'm also traveling along in Salem, sir.
I see the photo that you are doing some KMC with your belt, with your belt, with your belt.
Thank you, sir.
Right, sir. Right, sir. Thank you very much, sir, for your comments.
Thank you, sir.
Thank you, sir. Thank you.
Thank you, sir. It was very refreshing to hear it from a pediatrician, what they want, what they expect best from the maternity circuit. So I'm sure we all, whoever has attended this talk, will definitely very, very simple. Sometimes they say keep it simple. The big things are there in small gestures. So I'm sure those who have attended today's class will do it, sir. Thank you very much.
Actually, madam, for 1 minute, I discussed with many mothers and many grandmothers about this program. See, I always ask my PG, the ambition of the mother is to keep the baby in utero and ex utero along with her, not to let the baby in the bed. So that is being fulfilled. The expectation of the baby is with the mother always, whether in utero or ex utero. I think the answer is KMC, ma'am. Thank you, madam.
Thank you, sir.
Thank you. Thank you.
With this, we move on to the panel. And the panel this time is about GDM, something that we have to see every day, all practicing obstetricians. We have with us Dr. Meena Mahalingam, who will be the moderator. She is MD, DGO, DNB, MRCOG, and FICOG, MNAMS. She is an associate professor in Chengalpet Medical College. She's been the secretary, OXY, co-chair Urogynec Committee, OXY, and member of the Urogynec Subcommittee, FOXY. She's been specially trained in urogynecology, microsurgery, and endoscopy. She's been an instructor in the basic newborn care and resuscitation program under the IAP. 23 years of teaching experience in tertiary care center. Master trainer for IMONC, faculty and organizing member for a lot of national and international conferences. She's got a lot of publications to her credit and 5 original articles and a lot of other work like adolescent health camp, blood bank camp, district instructor in IAP, NRP, FGM training. And she's also a receiver of the scholarship from the IUGA for attending the conference in Italy. She's been adjudged the best doctor in 2024. Congrats on that, ma'am. And over to you. With her, we have a lot of panels. And myself, I'm one of the panelists, coordinator of TNFOG. With us, we have Uma Brinda, madam, who's working as an assistant professor in Tanjavur Medical College. Now she is the secretary of the Tanjavur OG Society and especially interested in high-risk obstetrics. Dr. Kavita, secretary Dindikal OG Society and consultant in Vishnu Surya Hospital, Dindikal. And Dr. Akila, who is an MBBS from Ramchandra Medical College, Masters from Annamalai University. She's also completed her diploma in cosmetic gynecology, underwent training at World Laparoscopic Center for Endoscopy and Kiel School of Endoscopy. She is currently the EC member in Trichy OG Society and been a faculty in a lot of national conferences. Dr. Nazia Shaikh, MSOG from Andhra Medical College, Visakhapatnam. Fellowship in Reproductive Medicine from Sri Ramchandra Medical Center. And her professional experience includes working at Mehta Hospital in the OG department as registrar, senior resident in Ramchandra Medical College, and currently she is at Sri Muthukumaran Medical College. And along with us, we have Dr. Divya, who is assistant professor in Sri Muthukumaran Medical College and Hospital. Welcome all panelists. Over to you, Meena, madam.
Thank you, Gayatri, for the wonderful introduction. So it's an open panel. So you can share your views. I'm going to share, as I'm traveling, I'm going to share my slides to Sahiti, and I'm not going to ask anything from the slides. So it'll be an open discussion from both ends. As we have a lot of time, you can stop me when it is we are starting at 5:52. We can finish by 40 minutes. So as we all know, GDM is carbohydrate intolerance of varying severity with onset of first recognition during present pregnancy. And we know pregnancy is diabetogenic.
You can start sharing the slide.
Sahiti?
Yes, ma'am.
You're there? Please start sharing the slide.
Sahiti, I couldn't get your line. I'm sending the slides to you only in your WhatsApp. I couldn't
yes, ma'am.
get
Please share,
connected in my
yes, ma'am. Please share in WhatsApp.
Yeah.
Ma'am, I have received 3 PPTs, ma'am. Which one I need to share, ma'am? Ma'am, you are not audible. Kindly unmute, ma'am.
Ma'am, you're muted now, ma'am. Meena, madam, you're muted.
Meena, ma'am.
Sahiti?
Yes, ma'am.
Sahiti, I've shared with you slides.
Yes, ma'am. 3 slides you have shared, ma'am. Which one I need to project, ma'am?
1 minute. Sahiti?
Yes, ma'am.
Sahiti, 28 slides ஒன்னு போட்டிருக்கிறது ஷேர் பண்றா.
Okay, ma'am. Please wait for a second, ma'am. I'm just downloading it.
Yeah, please. So till Sahiti is loading, today is the Diabetes Awareness Day, celebrated worldwide. That's why we are discussing this topic, because it is pertaining to diabetes in pregnancy. We are discussing gestational diabetes mellitus. So we know it is a carbohydrate intolerance of variable severity with onset of first recognition during present pregnancy. Pregnancy is diabetogenic due to the insulin resistance which is caused by human placental lactogen. And also there is increased production of cortisol, estriol and progesterone. And also increase insulin destruction by the kidney and also by the placental insulinase. And there is increased lipolysis. The mother uses fat for her caloric needs and saves glucose for fetal needs. There is change in gluconeogenesis. The fetus uses preferentially alanine and other amino acids and deprives the mother of a major gluconeogenic source. In pregnancy, there is facilitated anabolism and accelerated starvation. So the high risk factors for GDM, like we know family history of diabetes, obesity, older age group, previous big baby, anomalous fetus, ethnicity, Indian or Southeast Asian, previous intrauterine death, stillbirth, polyhydramnios, previous history of gestational diabetes mellitus, polycystic ovarian syndrome, metabolic syndrome, present pregnancy, like having a recurrent UTI, monilian infection, polyhydramnios, and macrosomia. So now, to my dear panelist, I would like to ask type of screening and whom we are going to screen. In India, what is the type of screening are we following?
Ma'am, India basically is a heart of diabetes population, ma'am. We have too much of diabetes and we have the food, the pattern of food itself is more diabetogenic, more of carbs, etc. So everybody should be screened with or without risk factor. First screening at probably the first visit, ma'am.
Yes. What
and in India,
Gayatri has told, yes, Gayatri, are done.
And in India, ma'am, we usually follow the DIPSI OGCT and 75 grams irrespective of the last meal. We give them and 2 hours later we see a plasma glucose. And up to 140 we consider it normal, ma'am.
Yeah, the take home message from what Dr. Gayatri is saying is excellent. We are going to do universal screening and it is not selective screening, as we are a diabetogenic state as well as country. We are the diabetic capital. So we have to do screening for all pregnant women. Excellent. Next slide. So we were having a doubt whether it is a universal screening or selective screening. So as Gayatri has rightly mentioned, we would go for a universal screening in the first visit itself. Next slide. Next slide. So in India, we are doing universal screening for all antenatal mothers. As in India, there is 11-fold higher risk of glucose intolerance. Next slide. Sahiti.
Just a second, ma'am.
Next. So as we know, there is one more screening selective is done in low prevalence countries where it is only limited to high risk women, which I mentioned already. Next. So the high risk is obesity, advanced age, family or past history of GDM, macrosomia, stillbirth or malformations. Next. When to screen? So can Akila, Nazia, Divya, Uma Brinda ma'am can take the question. When all we are going to screen?
Very good evening, ma'am. I'm Dr. Nazia. You have to screen like what exactly is the universal screening, and you should screen at the first antenatal visit itself. Because we don't know which women are have late conceptions, IVF conceptions, or only insulin intolerance, keto intolerance. Pre-diabetic, at the first antenatal visit, we have to screen. And suppose if HbA1c is more at the first visit itself, means more than 8 like that. So we all we tell them like there is no chance of fundamental anomalies, and like MPC. Otherwise, you can continue and start including the person. Next is other at the 24 to 28 weeks where glucose intolerance is the maximum, placental insulin. That time again we screen. These are important times we have to.
Yeah. So anyone, Uma ma'am or Akila, Gayatri, Divya, do you want
is
to
an
add
emergency,
anything?
ma'am. She said she'll join shortly.
Okay. Uma ma'am, do you want to add anything else? Gayatri, Divya?
Ma'am, the first screening is at the booking visit.
Yeah.
And the government usually recommends another testing at 12 to 16 weeks. If it is normal, 24 to 28 weeks. If that is also normal, 30 to 32 weeks.
Excellent, Gayatri. Next slide. Yeah, Uma ma'am, you can add on.
Yes, doing OGCT at first visit is difficult. And usually we follow at 12 to 16 weeks, 24 to 28 weeks, and 32 to 34 weeks in government setup. And we usually do an RBS during the first initial booking visit.
Yeah. Thank you, Uma ma'am. As rightly
Ma'am,
said,
can I ask
Uma
a question,
ma'am?
ma'am?
Yes, please.
Ma'am, we usually say that the placentation is completed by around 20 weeks. So for the whole hormone levels to take over and GDM to present itself, it takes 24 to 28 weeks. But sometimes when the patients come to us for a checkup and other things, they are doing in GH, they are doing a GCT much earlier, like 21, 22 weeks. Are we supposed to take it or repeat it at 24 to 28 weeks?
What the government says is, ideal test is 12 to 16 weeks at the first visit to the antenatal clinic. The next, if the first report comes as less than 140, we think she's normal, do a second diagnostic test at 24 to 28 weeks. And that too is normal, then we do a oral glucose challenge test at third trimester between 32 to 34 weeks. Generally, what Seshia sir test recently, what Anjalakshi madam has... Yeah? Hello? In Medcode app, what they are trying to do is trying to do a test as 11 weeks postprandial. If it is more than 110, they are trying to start metformin and then repeat after 2 weeks to see if she is to control fetal onset of diabetes. So fetus is acting as a predictor. So these are the tests which are being done. Now, these are the guidelines given by the NHM. So this is what is to be done. As Uma madam has rightly mentioned, we are not doing in the initial visit because the patient may have vomiting. She may not tolerate the glucose which is mixed with water and given. She may vomit. That is the reason we are not doing it in the early weeks. Next. Am I clear, Gayatri?
Yes, ma'am.
Because we can treat women if we are going to diagnose in the first trimester itself. It is not about the placentation. It is the fetus.
No, ma'am, it's not the first trimester. When they come at 24 weeks and we ask them to do the GCT, they give us a report from the government setup and the GCT is already done at 21, 22 weeks.
Yes. Usually you are supposed to do only 3 times, 12 to 16, 24 to 28 and 32 to 34. If the patient is missed, there may be a difference in the weeks when we are doing. Yeah, okay, Gayatri?
Yes, ma'am.
Yeah. Then how to screen these women? Dr. Divya? Divya is not there. Dr. Gayatri?
Ma'am, irrespective of the last meal, we give them the glucose load. And we take one venous sample after 2 hours, ma'am.
Yeah. Sahiti, next slide. So we are generally doing one-step method. What Gayatri was mentioning is the diabetes in pregnancy study group of India. We are not following this IAD, PSG and WHO criteria, not two-step method because it is cumbersome for these women who come to the government sector, which we do not want to have a missed GDM in the first trimester itself. Next slide. So as mentioned rightly, irrespective of the previous meal, even if she has taken a breakfast, even if she has had an overnight fast, doesn't matter. We take 75 grams of glucose in 200 or 300 ml of water, or even a lemon juice, and the blood glucose is checked 2 hours later. Next. So the interpretation of the test. How are you generally interpreting? Uma ma'am?
Yes, madam.
Dr. Nazia? Yeah.
Madam,
How
to
are
ask
you
post
interpreting?
glucose load, we should see the sample is taken in venous blood, and any value more than 140 is abnormal, madam.
Yeah. More than 140, we brand it as GDM. This is a screening test. If the value is coming as more than 140, it is GDM. If it is less than 140, we do repeat the test as second and third trimester.
Yes.
So
Yes,
basically, the cutoff taken at 140 can detect 80% of the women. If the cutoff is reduced as 130, we can pick up women, 90% of the women as GDM. Next slide.
Yes.
Thank you. So what are all the advantages of DIPSI? Next slide.
We
Dr.
don't
Divya?
need a fasting state. That is the most important advantage of DIPSI criteria, ma'am. We can do any setting. It is a single step method to diagnose GDM. And the most important one is no need of fasting state.
And it is also a single step, ma'am. They don't have to come again and again.
Yes. So person is message kindly. They cannot hear. Am I audible? I can hear.
Yes, ma'am, you are.
You are okay. So as Dr. Gayatri and Dr. Uma ma'am has mentioned, it is a single step screening as well as it is diagnostic. No need to go for another test by doing a 2-step or a 3-step method, and it is patient friendly because there is no fasting irrespective of the previous meal, and useful for large population screening. Even it is done at the primary health center level. Next. And where to screen? Next. Where do we screen these women?
Any healthcare
Dr.
facility
Nazia?
lab, ma'am, with facilities for just RBS estimation.
Yeah, anywhere. It can be done in the primary health center, sub-center, tertiary hospital, private hospital, government hospital. Only the blood sugar test needs to be, the blood sample needs to be taken. That's all. Next. Next slide. Sahiti. So we have a case here. So this is a second gravida, 32 years. She is BMI is 29 kg per meter square, diagnosed as GDM at 24 weeks of gestation. She was on medical nutritional therapy for 2 weeks. So generally, once we diagnose women as GDM with one cutoff value more than 140, we start them on medical nutrition therapy. That means to say, she'll be given the diet, 3 meals and 3 snacks, a little bit of exercise 3 times a week, as well as the monitoring will be done, the sugar values after 2 weeks. Now, the sugar values fasting is 105 and the postprandial is 165. So, which treatment modality you want to start? Next slide.
Are
Next
the
slide.
other panelists joined?
I do not know. Only
only looks like only me and Uma madam are there.
Yeah, Dr. Kavita
Dr.
is not there.
Me that she's got an emergency.
Yeah, Dr. Kavita ma'am is not available. I am not
Dr.
sure
Nazia,
about Dr.
Dr. Divya.
Nazia is there.
Yes, ma'am. I'm there, ma'am. I can hear now.
Yeah. So what is that? You would like to start them on insulin. Why? Next. So in this case, you have tried medical nutritional therapy and you are moving with insulin because the postprandial level is elevated. What is the insulin you would like to start? She is para 1 live 0. She has come with the elevated postprandial. What is the type of insulin you would like to start?
Ma'am, I usually start on Act Rapid for 3 times and an insulin attack in the night to take care of the fasting insulin, ma'am, fasting blood sugar, ma'am.
Yeah. Next slide.
I am very happy with the control this gives, ma'am, rather than mixed start.
Yeah. So anyone has a difference of opinion?
Madam, usually diabetologist or physician, they are convenient with mixed insulin, madam. Twice daily dosage. The patient also feels it convenient. And we usually start as mixed.
Yeah.
And even
So,
NHM guidelines also advise.
The NHM guideline says mixed.
Mixed,
yes.
yes.
So,
Mixed.
so in the
They
government
advise
sector,
mixed
we are
to
following
patient.
the NHM guideline, and usually we take a opinion. By the time she comes with the opinion, we do start them on insulin. So the ideal insulin in pregnancy should mimic or give a physiological control. That is the idea. No adverse effect upon maternal and fetal outcome. There should not be any interference with the antenatal, perinatal and postnatal care. Insulin should not induce antibody generation. That is, IgG bound insulin can cross the placenta. That is the idea of taking the ideal insulin. Next slide. So we have different analogs. So we need to know about different analogs. So Gayatri was mentioning the analogs as well. We have Lispro, Aspart, Glucin, Glargin, Detimer. All these, they have a rapid or a long acting. So in rapid, mainly we do have the category B, and Glucin we are not using generally, it is C. Glargin and Detimer, C and B category of drugs. Generally, we give both B and C category during pregnancy. Next slide. So how will you initiate and titrate the dose of insulin? Next slide. So how are you going to start the insulin for this woman? So she's already tried medical nutritional therapy and you're planning to start them on insulin. What is that you're going to do?
Practically, I admit them and start, ma'am.
Yeah, so
it's
admitting
almost a
will
trial
be
and error method. Start with the dose which we feel is okay and step it up slowly because risk of hypoglycemia will be there.
Okay. Uma ma'am, any difference of opinion?
Differences?
Nazia? So generally, once we are starting them on insulin, we admit the patient because the patient can go for hypoglycemia and it is going to be titration based on the sugar values. So first trimester, usually it is 0.7 units per kg. Second trimester, it is 0.8 units per kg. Third trimester, it is 0.9 to 1 unit per kg. So it is trimester wise and weight based dosing. Generally, 2/3 of the total dose, usually we give it in the morning. That is how we are following, no? 2/3 in the morning, usually combining 1/3 insulin aspart or Lispro with breakfast, 2/3 of NPH insulin. And 1/3 will be given in the night. In that, we give half insulin aspart or Lispro with dinner, that is rapid acting, and half NPH before bed. This is the normal thing what we follow. So in GDM, the requirement of insulin is roughly half of the pre-gestational diabetes. In diabetes, usually the requirement is a bit higher, and fasting hyperglycemia is there. Then basal insulin doses, you have to give 0.1 to 0.2 units per kg. Next slide. And postprandial values are high. Usually, if we give the morning dose, we have to increase. What are the disadvantage of using insulin? Next slide.
It's invasive.
Dr. Gayatri, yeah, invasive.
Some people are very scared. It requires a lot of motivation from them. Sometimes they may default. And of course, hypoglycemia, based on suddenly they may have some vomiting and other things. But without knowing it, they would have taken their insulin.
Yes.
You're risking them
So
for
usually,
hypoglycemia.
yeah. Dr. Uma ma'am?
Yes, madam. Mainly the risk of hypoglycemia if they are not taking their diet properly and injectable. That is the
One more thing I want to add, ma'am. Storage is another disadvantage with insulin. Like everywhere we don't have
in low
storage.
status society.
Yes.
It's very important.
Especially in
storage
government
as well.
hospitals, ma'am. Yes, ma'am.
Yeah. So usually the staff nurse maintains the insulin and she gives the insulin as written by the doctor. Usually.
If we keep for long time, precipitation also will happen, which might sometimes lead to reaction. Previously, that patient would have used, but that same ampule later on get precipitated, ma'am.
Yeah.
That is also there.
Yeah, so the important thing is storage problem as well said, and inconvenience of repeated injections. The patient may not feel comfortable, and the high cost. There can be weight gain, and there can be repeated episodes of hypoglycemia, which requires intense monitoring. Next. How will you adjust the dose of insulin while giving antenatal steroids? So generally, we expect these women to have a problem when we are going to give steroids. So how are we going to manage these women when they are going to be given steroids? What is the steroid which you generally give in your practice?
Dexamethasone,
We
ma'am.
generally use dexamethasone, ma'am.
Betamethasone, that salt is not available in India.
Okay.
Yes. But
So
still,
actually,
we see some persons using betamethasone
yeah.
also.
So actually, in our private, we have betamethasone injection, and betamethasone tablets are also available. In the government sector, we are giving dexamethasone injection. So once we are giving, how are we going to titrate the dose? Are we going to increase the dose of insulin?
Yes, ma'am.
For up to 24 to 48 hours after the last dose of steroid, we have to increase it about 30%, ma'am.
Yeah. So it is just an increase of what the normal dose is. In day 1, we increase the night dose of insulin by 25%. Day 2 and 3, we increase by 40%. Day 4, we normally bring it to 20%. And day 5, bring it to 10 to 20%. Day 6 and 7, gradually taper the insulin dose to pre-steroid level. So generally, what the theme of this is, once we are giving a steroid, you need to increase the dose of insulin. Next.
Ma'am, is it same with betamethasone, dexamethasone, or like a different?
Yeah, it is the same.
Oh,
It is
okay.
the same. Next. So
Next, which slide I need to project, ma?
Yeah, 1 minute. Sorry for the inconvenience. As I'm traveling, I couldn't.
Is it GDM second case or labor and
Slide,
GDM?
26 slides are there, no?
Yes, ma'am.
In that, go to slide number. Just a minute. Third case, 19th slide.
Okay, ma'am.
Yeah. So this is another case. 35-year-old primary gravida. She's on GDM on insulin, plan for induction. What precautions you will follow before induction? Next slide.
Ma'am, this is Nazia, ma'am. We will admit the patient around, suppose GDM is controlled on OHA, she's not on insulin, then we'll admit ideally at 38 completed weeks. And then just before induction, with on which type, depending upon the type of induction, ma'am. And then we have to titrate the dose of insulin during when patient goes in labor, like when we keep like only liquid food or meal oral. That time. Half of the actually if she is on insulin, then we have to give half of the dose of morning insulin, and then see we'll keep gel or miso whatever is possible, then start insulin IV if she goes in active labor, ma'am, and we will check CBG every second hour.
Yeah. Generally, we are going to give a Foley induction. There is no need to stop insulin. But once we are going to, we know that she may deliver. In that case, induction, if you are going to do elective cesarean, we do not give the morning dose of insulin. We take the fasting blood sugar level and then do the cesarean. But if it is going to be a day before induction, if you're going to give a gel induction, normal diet, normal insulin dosage, and there should not be any overnight fasting. You can ask her to take 10 o'clock. Then in the morning, take the day of induction, give half morning dose of insulin before light breakfast. Insert prostaglandin gel as early as possible. continuous CTG, start IV insulin infusion once labor establishes based on the sugar values. So I can see a question in the chat box. Dr. Kavita Saravanan is asked, but I'm not able to see her question. Can anyone read that question? Gayatri?
Yes, ma'am. What is the blood sugar value reduced by 1 unit of rapidly acting insulin? How to adjust the dose?
Can you answer that?
Ma'am, it depends on people to people. We can't say it exactly. So usually it is by trial and error method only. Each one will react differently to it.
Yeah. The thing is, based on
There
the
is no
sugar values.
textbook level.
Yeah. The thing is, each individual person may have a different titration based on the sugar levels. Basically, after starting insulin, we do a glycemic profile that is called the 5-point profile or a 7-point profile. 5-point profile will be taking fasting and postprandial following each meal, and 3 a.m. we do a blood sugar level. Based on that, we can even do a home-based glucose monitoring. That is what Manjula madam has answered in the chat box. Based on the sugar levels, if the postprandial sugars are high, we need to increase the rapid insulin levels just before the particular meal. But if the fasting is raised, we need to titrate the night dose of long-acting insulin. That is what we need to remember. I hope I am clear to Dr. Kavita. Next slide. Next slide. So the maternal glucose monitoring in labor. We need to avoid maternal hyperglycemia and hypoglycemia. That is why we keep a target of 70 to 120 milligram per deciliter. So this reduces the risk of neonatal hypoglycemia. Whenever we are doing a capillary blood glucose during labor, the cutoff should be maintained between 70 to 120 milligram per deciliter. The next slide. Intrapartum blood glucose monitoring, the targets. Next. What are the targets required? Nazia?
Yes, sir.
Nazia, are you there?
Hello, am I audible, ma'am? Yes, ma'am. Yes, ma'am. I'm there, ma'am.
Yes.
Am I audible, ma'am?
Yes, you're audible.
Yes, ma'am. During intrapartum and during the delivery process, we'll maintain sugars around 100 to 120 mg per dl, ma'am. Will not allow to go below 80 as it causes neonatal hypoglycemia and it affects the mother also. I mean, in total, it's like 4 to 7 millimoles per liter.
Yeah. So
And
do
also,
not have a sugar
suppose it
levels
is
go
going in
beyond 70. Yeah. Next slide.
Yes, ma'am. Below 70 or 80, we'll not allow it to go.
Yeah. So generally, when the
If
sugar
the sugar
levels
are getting more,
yeah.
if it is
Yes, go
like
on,
if more than 120, yes, 120. If it is more than 120, ma'am, like we'll ask first 4 units and then we'll see. If it is controlling with that, we'll go with the same drip, ma'am. Suppose if it is like in between, like 140 or 160, 180, like that, then 2 more units will add, like total of 6 units. If it is more than 180, like 200, 220 in that range, we'll add 8 units and then we'll see, ma'am. It's like a sliding scale. There is no fixed dose like that. 2 units for every 20 or 30 mg per dl we have to add.
Okay. So Manjula madam has typed rapid acting insulin half-life is 6 to 8 hours. So in this particular case, blood sugar level is 90 to 120 means there is no need for any insulin. Just a normal saline is enough. If the levels go beyond 120 to 140, make it 4 units. Then 140 to 180, make it 6 units, and more than 180, make it 8 units. 100 ml per hour. That will be 16 drops per minute. Next slide. Gayatri, can you read what madam has typed in the chat box? Manjula madam.
Ma'am, her first query was about home-based glucose monitoring.
Yes, you
And the next
can do a home-based glucose monitoring if the woman is
it's a game changer
educated and
according to me.
compliant.
Exactly,
Yeah?
it's a game changer. Yeah, it shows our commitment. And nowadays, with media available, they take it every 5 days and send it to me by WhatsApp. So tight control is being, a lot more easier with the home glucose monitoring and their commitment.
Yeah, that is true. So home-based glucose monitoring should be given to women who are educated and who can titrate the dose, who can pick up hypoglycemia and correct their sugar levels based on the home blood glucose monitoring. Then madam has typed something which I am not able to see.
Ma'am, the second question is, rapid-acting insulin has a half-life of 6 to 8 hours. Long-acting has around 12 to 14 hours. Accordingly, can we measure fasting and postprandial sugar levels every meal and adjust? Yes, ma'am.
Yes, in the initial phase, we do adjust the insulin based on the sugar levels which are taken fasting, postprandial, that is
Post-lunch and post-dinner.
Pre-lunch, post-lunch, pre-dinner, post-dinner at 3 a.m. That is how we titrate, madam. So the rapid-acting insulin works for 6 to 8 hours. So the postprandial levels are high. We need to increase the dose of the short-acting dose which is given in the morning. And if the fasting levels are high, we need to increase the dose of intermediate acting or long acting which is given in the night. Hope I am clear.
Ma'am, sorry to interpret. I'm Dr. Kavita Saravanan.
Yes.
And
Yes.
my doubt is, if the patient is already on insulin and her post-breakfast level is around 160, say, she is already on 4 units of morning act rapid insulin. And how much? Now it's 160. We need our target to be around 120. For that 40 milligrams, how much insulin we have to increase the dose? That's what I'm asking for. How many units of insulin will reduce the blood sugar by how much milligrams?
Ma'am, you can't say that for sure. What I usually advise them is to just increase by 2 units.
Okay.
And the next day again, they are advised to check the whole thing.
Yes.
2 units of
That is what we do, madam. Generally, we increase, as Gayatri has rightly said, we generally increase by 2 to 3 units when we are titrating ourselves. But if we have in our setup, in the government sector, we get a diabetologist opinion once we get the 5-point profile. They do increase the dose of insulin by 2 to 3 units, madam. Then again, after 2 to 3 days, we repeat the 5-point profile to see if our sugar levels are titrated to the required amount. What we have expected. Hope it is clear, Dr. Kavita ma'am.
Yes, ma'am. Thank you.
Yeah. So in the government sector, we are advised to take opinion of the physician or the diabetologist. With the values, we just send the case sheet and they give an opinion as to how to increase the dose of insulin, which in our private sector, we, as a holistic approach, we do increase the dose and check the sugar levels, madam. Next question. Next. So adjust the insulin at risk of hypoglycemia. Mainly, we need to encourage the women to breastfeed once she has delivered, reducing the neonatal hypoglycemia, offspring, obesity. Metformin and glyburin may be used during breastfeeding. No long-term data, but apparently they are found to be safe. And screening for postpartum thyroiditis and type 1 diabetes is important. Check TSH at 2 to 4 months postpartum. This is postpartum care for pre-existing diabetes. Next. Next. Sahiti? Sahiti, you can share the last one.
Okay.
Yeah, last one. Shared one more. So we have dealt about the goal of intrapartum management. Anything you would like to add, Gayatri, Nazia?
No, ma'am.
So main thing is the cutoff.
Macrosomia and we have to take care that we don't land up with the birth injuries.
Yeah. So avoiding maternal hypoglycemia. Yeah.
Otherwise, fetal will go in hypoglycemia, seizures might come, and which might lead to asphyxia or HIE. So hypoglycemia, you can never let the patient go in that. And anyhow, that process of labor is a stressful event. Even the patient is on meal oral, even if she didn't eat anything also, there will be a little higher levels of sugar values. Make sure it does not go into hypoglycemia. It doesn't mean that it should go above 200 like that. So sliding scale and monitoring is very, very important to avoid complications. And as usual, like it has its own complications during the phase or like the delivery. Shoulder distortion might be there, like something forceps, use of forceps, like it's going to be more chance of making like all that has to be calculated. And the patients are both good.
Yeah. So main thing is maintain the euglycemia, avoid maternal hypoglycemia. Main thing, we are worried about the baby as well. Mother's hypoglycemia, baby's hypoglycemia, and the risk of shoulder dystocia. So shoulder dystocia, we can just predict if there is a delay in the descent or the head is still not got into the cavity and the shoulders fail to enter the cavity. That is how we are generally identifying shoulder dystocia. Next slide. When should we plan to terminate the pregnancy? Dr. Uma ma'am?
In GDM, the risk of term IUD is quite high. I usually don't allow them to go beyond 39 weeks, ma'am. Before 39 weeks, I plan their delivery, ma'am. 38 to 39 weeks.
Yes. Nazia, anything to add? So generally, if it is a diet control with GDM and no complications like macrosomia or hydramnios, we can wait for spontaneous labor up to 40 weeks. This is what the guideline says. But we are all scared about the unexplained intrauterine death. That is what really we need to look into. So insulin requiring GDM with well-controlled blood sugars, no complications, induction can be done at 38 to 39 weeks. So we are going to deliver at 37 weeks. If there is going to be a poor glycemic control, there is macrosomia when the predicted baby weight is 4 to 4.5 kg, or there is associated complications like preeclampsia or any other fetal compromise like FGR. So general consensus is 37 weeks in uncontrolled and controlled with insulin 38 to 39 weeks. Control with diet, no other complications. You can allow them for spontaneous onset of labor for 40 weeks. But always remember there is a risk of intrauterine death, macrosomia and shoulder dystocia. Next. Next slide. Next slide. So obstetric management. Anything to add in the obstetric management, Dr. Uma ma'am? Gayatri?
Ma'am, no, ma'am. The slide says everything, ma'am. We have to be very careful and mark the partogram because we have to find out if there is any delay or descent at an early stage itself.
Yes, ma'am.
A prolonged trial is not advised.
Quick and prompt decision is required to avoid shoulder dystocia, ma'am. First thing, that's what we are scared of. Head will come
And
and then it
prolonged
gets
trial of
that is
labor
the
is
thing.
not accepted generally.
Yes,
Yeah. So maintaining the progress of labor using a partogram or where possible, a labor care guide, a skilled attendant, monitoring the sugar levels and monitoring the fetal heart rate using continuous tachography also will help if there is a availability. Macrosomia by using AC measurement. Yes, ma'am. Macrosomia usually picked up by AC and estimated fetal weight more than 90th percentile. That is how we are going to do macrosomia assessment. Basically, it is the ultrasound assessment of the fetal weight and the abdominal circumference. When the graph goes beyond 95th percentile, we know it is a macrosomia baby. Next slide. So, monitoring the capillary, this all we have dealt already. And regular insulin is infused at a rate of 1 to 1.25 units per hour if glucose level is more than 120 milligram per deciliter. That's what we are telling. It's a insulin infusion given along with the normal saline drip. Next. So the sliding scale, which we have already mentioned. The next slide. So pain relief. How are we going to give pain relief in these women?
pain relief is more important, ma'am, because there is a more stressful event and we usually prevent such stressful things. Usually epidural epidural is better, or we can give that inhalation analgesics. So these two are commonly used, ma'am. Suppose patient is in labor. I feel that epidural is better for.
Gayatri, you want to add anything?
No, ma'am. Epidural, they can be given, ma'am.
Yeah. So epidural or Entonox we can give. Because if there is a pain, there is going to be a catecholamine release and induction of hyperglycemia in these women. Next. So if oxytocin infusion is required for the augmentation of labor, usually we prefer to give with normal saline. And prophylactic antibiotics are started to prevent infection. And as women are reaching active stage of labor, ARM can be performed to detect any meconium in the liquor or labor progress generally monitored with partogram. Next slide. Mode of delivery, is there anything specific to be told, Gayatri?
Nothing, ma'am. If there is a macrosomia, we'll have to counsel them about the risk of birth injuries. And if they're not willing, it is preferable to do than a traumatic vaginal delivery. A safer cesarean section will be better. But when the control is very, very strict, and when there is no risk of macrosomia, we can go for a vaginal delivery, ma'am.
Yeah, so there is no contraindication for vaginal delivery. Madam is measured only patients with insulin LSCS only. All patients with insulin. It's not like that, madam. Even with women on insulin, we can give normal delivery if there is no risk of shoulder dystocia, and we have good setup for monitoring the baby's progress with the partogram as well as the CTG.
And especially if the sugar control has been tight, we can definitely give them the opportunity.
Yeah. But if the baby weight is suspected to be more than 4 to 4.5 kg, elective cesarean section is preferred.
Better.
And if there is a malpresentation or any other risk factors are there, we can go. If there is a FGR also, we can just decide on cesarean section.
The threshold for decision for cesarean can be lower.
Yeah. So the as well said by Gayatri, it is a lower threshold for cesarean section. No need to prolong the second stage. And skin and nutrients incision should be larger. We should not have a tough time to deliver the baby. Diabetic control, sliding scale, and thromboprophylaxis if there is obesity or if the woman is immobile. So it is very important, thromboprophylaxis. Next slide. So in the puerperium, anything to be monitored in the puerperium?
Yes, ma'am. Like usually once the delivery is over, after the delivery, insulin requirements will drop and the sugar levels also will drop. So you need not start the dose which you have given in the pregnant time. And usually on third day, we'll check FBS and PPBS and decide whether to do only oral or you stop or like that. And also sixth week of postpartum, again, we have to check for all these patients, ma'am. Along with this, we also check TSH thyroid profile we have to do if it is type 1 diabetes for these patients. And the contraception is must for all these patients. Suppose it's the primary, we generally advise contraception. And like infective prophylaxis and IV antibiotics are also given to prevent infection.
Yeah. So prophylaxis against infection is very important. Thromboprophylaxis is important. Insulin level, insulin may not be required in these GDM mothers. And doing a fasting postprandial on third day is important. Support them for breastfeeding, giving adequate contraception and TSH if type 1 diabetes. And 6 weeks follow-up is very important to find out if these women are going in for type 1 diabetes as well. Because the GDM has a 50% risk of going in for type 1 diabetes. Next. Next slide. Previous one. Sahiti. Next one. So breastfeeding is not contraindicated and it allows the body to use extra calories stored during pregnancy, allowing for weight loss. Helps to reduce the risk of developing type 2 diabetes in future. It's also believed to help lower the blood glucose levels in mothers as well, as it is going to consume calories. Next slide. Next slide. So postpartum care, as already we have told, 50% risk of developing over diabetes within 20 years. It is important that we need to do a 75 gram OGTT to determine glycemic status, ideally 6 to 12 weeks postpartum. Next slide. So what are the neonatal complications which are anticipated, Gayatri? Nazia? I think their connection is cut. I will just proceed. Respiratory distress may develop even in term babies. This for hypoglycemia, hypocalcemia, hypokalemia, hypomagnesemia, and polycythemia due to chronic hypoxia can lead to renal vein thrombosis. Also, hyperbilirubinemia can come, increase incidence of diabetes in later life. Next slide. So it is important to check the baby sugar levels. If it is less than 40 milligram per deciliter in term neonates and less than 30 to 35 milligram per deciliter in preterm neonates, we call it as neonatal hypoglycemia. So we need to assess the hypoglycemia 1 to 2 hours, 4 to 6 hours, and 24 to 48 hours after birth. And if hypoglycemia is diagnosed, initial bolus 2 ml per kg of 10% dextrose. Continuous infusion should be given 6 to 8 mg per kg in term babies, 8 to 10 mg per kg in preterm babies. Next slide. So what are the contraceptive options for these mothers? Nazia? Gayatri, are you there?
Ma'am, I advise PP IUCD, ma'am.
Yes. Next slide. So generally we go for either low dose oral contraceptive pills or progestin. Usually it is the IUCD which is the preferred. We can cut the thread very short to prevent ascending infection, barrier contraception if they are willing, and tubectomy if they have completed the family. Next. So for next. Thank you. So thank you. We are on time. Any take home messages, Gayatri, you would like to share?
Yes, ma'am. In India, NHM advises DIPSI method of screening for all the population. And we had a slide which said that the first screening method is 12 to 16 weeks. Second one at 24 to 28 weeks. And if both are normal, again repeat at 32 to 34 weeks. And we spoke about insulin being the best one to treat it. If medical nutrition therapy does not succeed in 2 weeks, we have to take it up for insulin, how we admit the patient and titrate the doses. Yes, preferred is according to the patient is mixed start, but some people also use the latest ones and the short acting ones. If the control is extremely good and only on diet, up to 40 weeks, we can wait. And patients on insulin, we can, 10 days before due date, we can start inductions. And if there is risk of macrosomia, non-traumatic LSCS is preferred to a very traumatic vaginal delivery. And how we also spoke about how we have to stop the insulin when and monitor blood sugars during labor and how to start insulin in case of hyperglycemia in the intrapartum period. And we spoke about indications for cesarean and vaginal delivery, postnatal and post-op follow-up, and contraception in them. Again, I usually tell my patients that this is the first and best master health checkup a woman can have in her life. So in case they have been diagnosed as GDM now, it means that they are likely to get this disease in the future life. So they are supposed to keep monitoring them every year and advise them on lifestyle changes, which can really at least delay the occurrence of diabetes mellitus in them. Ma'am, have I missed anything, ma'am?
No, excellent compilation. So main thing is elective induction is only for uncontrolled diabetes. And also one more thing, metformin, if the patient is on metformin for a polycystic ovarian syndrome, we can continue metformin instead of starting insulin. The latest guidelines support metformin also being tried for women who are diabetic or who are on GDM diagnosed. So that is usually tried in second and third trimester. If she is PCOS on metformin, she can continue even in first trimester. It is a safe drug. Nazia, you want to add anything?
Uma madam.
Nazia is there? Anything you want to say as take home message?
Uma madam.
Madam has
Uma
given
madam?
all points in
Uma madam, you want to say anything?
Postpartum,
I hope
6
it is
weeks
clear.
postpartum. Yes, madam. Postpartum, 6 weeks postpartum OGCT.
Yeah. So it is
We are not.
OGTT.
Yes.
Yeah.
That should be fun, madam. And
Yes. Nazia, you want to say something? Take home points. I think it is very clear for managing a GDM. All my panelists have given clear ideas. Dr. Gayatri, Dr. Uma Brinda ma'am, and Dr. Nazia. And I think Dr. Akila, Dr. Divya, and Dr. Kavita could not join. So thank you, Gayatri, and thank TNFOG Marathon CME team, Dr. Sampath Kumari ma'am, Vidya Prabhakar ma'am, for having given me this opportunity to moderate the panel on GDM, which is on Diabetes Awareness Day, that is November 14th. Also, Dr. Radhika Gauri, I think she's there.
My co-coordinator, ma'am.
Yeah, co-coordinator, my friend. Thank you so much. If there are any questions, you can take. Thank you, thank you. If there are any questions, you can take Gayatri. The chat box, we can answer.
Ma'am, we have a few questions, ma'am.
Yeah.
No, ma'am. Actually, only two. Macrosomia is by using AC measurement.
Yes.
I think we agree to it.
Yeah. Yeah.
Yeah. The next comment, I'm not able to understand it. It says only patients with insulin LSCs only. I don't know if it's a question or a statement.
No, all patients on insulin does. Yeah, need not go. Next.
We can give them a trial if the control is satisfactory.
Yeah.
And another question is how long to give thromboprophylaxis in these patients, ma'am? Post-op.
Thromboprophylaxis, the indication is based on the risk factors. If the patient has had only emergency cesarean, it is for 7 to 10 days. If there are multiple risk factors and if she is on heparin earlier itself, we need to continue till 6 weeks. If she is a high risk woman. Low risk women, generally we go till 10 days, 7 to 10 days. If there are no questions, I think we can
These
close.
women benefit a lot by early ambulation.
Yes.
Like the one we proclaim in the enhanced recovery pathway.
Yeah. If they have undergone surgery, we can go for a enhanced recovery. Otherwise, early mobilization as said by Dr. Gayatri. Yes. Thank you, Gayatri.
Thank you, ma'am. Thank you, my co-panelists. Thanks. It was a wonderful session. I think we touched all the aspects of Madam has given a comprehensive GDM package here. And coming to a formal vote of thanks, I really thank our both our chief guests, Dr. Anju Soni and Dr. Kunju Moideen for taking. Kunju Moideen couldn't join us, but please, he was willing to be available with us to bless our program. Thank you, Anju Madam, for sharing your blessings to us, and our judges who've been with us throughout this marathon, the Yuva speakers, all the other speakers and panelists, Meena Madam, for your time and your efforts. I also thank the delegates for joining in, because if they don't join in, nothing is going to be a success. Success is not spelled without them. And also Shield Connect for giving us this platform. Thank you all.
Thank you, Shield Connect Saiti, for having given us the wonderful thing to share as and when we
and
needed.
Thank you, Shri Priya Madam, for the event management, wonderful event management each and every month.
Yeah. Thank you, Shri Priya and Saiti. Thank you, Gayatri.
Thank you, ma'am.
Bye.
Thank you, ma'am.
I think
Bye-bye.
close the session. Before
Yes,
time. Yeah.